Hi, folks. This is Dr. Rob Cywes. I am the carb addiction doc, and I have the thrill, the pleasure, and the honor of welcoming Dr. Mark Cucuzzella to the stage. And just before we were talking, Mark and I, is that I've known him for a long time, and it's just amazing to see the massive footprint. He is a runner, so it's a big footprint as well that he's put on the ketogenic low carb space. And Mark is one of those people like myself who is a practitioner. He's in the trenches. He's taking care of patients every day. He's ordering blood work. He's seeing progression. He's not out there postulating and armchair recording and reading stuff. He's obviously reading, but he has real world experience in the trenches with a tough group of people. So Mark, welcome. And can you give us a better introduction for who you are, what you're doing, how you got into this briefly, please?
Well, gosh, well, Rob, it's a privilege to be on your YouTube. I've listened to episodes, especially the ones revolving around the sports science and Prof. Noakes. I think I got introduced to you just virtually because I watched Prof's original conference in South Africa. What was that, 2015?
Was
The one that
either 12 or 15 sometime.
Yeah, it was a long time ago. Yeah, and he brought you on, as a fellow South African who was a pediatric bariatric surgeon. And, then I believe at that time you weren't in Florida, but I've met you. I think I met you first at Boca, maybe like 6 or 7 years ago at one of Doug's conferences. So I've followed your work. But yeah, my background, so I'm a family doc, so international listeners, a GP, if you're in the UK. So I'm primary care. So, but I do have a board certification in obesity medicine also. And also I'm certified through the Society of Metabolic Health Practitioners. So Rob and I are on the board of that organization. So we're trying to start our own specialty organization on metabolic health. So I feel proud to be in that group and learning constantly by our own conferences. Got into low carb almost by accident, out of my own personal health history and by working with the military. So I was tasked in about 2012 to help military members pass their fitness test. And I was the running doc, and there was this big running component, and there's all these running injuries. And, they brought me in to help because the hypothesis was people just need to learn how to run better. And I looked at the data on why people were failing, and I saw a direct correlation between, correlation causation. I think you've talked a lot about that. So we don't know, but there was a direct correlation between your BMI and your fitness test failure rate. Right. And I think any of you that run, it wouldn't be too self-evident if I put a 60-pound rucksack on you, it'd be a little more difficult to run. And so I had 6 months to work on this project, and I never really studied obesity, right? I was a GP in the States, and basically what I learned was what we were told: eat less, exercise more, 500 calories a day deficit. In a week, you'll lose a pound, and in a year, you'd lose 50 pounds. Right. I guess if you kept doing that, you'd be back to your original birth weight. Yeah. So for me, that would have taken about 3 years, and I'd be back to 6 pounds, 4 ounces, if that all worked out. So I traveled to 50 military bases, and I was curious. I started reading. I would ask this question, at military bases, has anyone lost 50 pounds and kept it off for a year? And I'd be in the base gym, with all these people that didn't want to be there. They were all the fitness test failure people, and one person would raise their hand, maybe two, and I'd be, if it was you, Sergeant Rob, what'd you do? And across the board, it was always some flavor of, well, I got rid of bread, I'm doing paleo, got rid of all the drinks and the sodas, and the courageous one would say, I did Atkins, because I was a doc. They were afraid to say that. They were like all these closet Atkins people back then. And, paleo in 2012 meant like you kill it, right? It wasn't an aisle at Costco with, paleo junk food. Paleo is, you gather it or you kill it. So it was basically a low carb diet, eating real food. And then I ended up in my own health condition developing what's called maturity onset diabetes of youth, which is a low insulin condition. So kind of a little after that time when, it was 100% correlation with the people losing the weight and carbohydrate reduction. I had to do my own little N of 1 experiment, put a CGM on, and it was a mess. I was a runner, ate with carb heavy, hemoglobin A1C near diabetic range, having hypos at night, going into the 40s. I didn't know that was happening. It had been happening for about 2 years. I was waking up every morning, 2 in the morning. I thought it was just because I was running and burning a lot of energy. I was losing weight. I needed to eat like these monster bowls of cereal. It was crazy thinking about it now with what I do now. Like, it should have been pretty obvious what was going on. And, but it wasn't. No one really understood those conditions. So I had to turn the food pyramid upside down, completely, to not be medically boarded. So since about 2012, I've been probably 90% carnivore, right, with some veggies around the side, and not difficult now, but, I've got a CGM on my arm and I feel good, so I feel blessed that I had the opportunity to learn from people before I got sick myself, because I don't know what I would have
So what
done.
is your A1C now, Mark?
My A1C now is like 5.6-ish.
Okay.
Yeah, that's what my CGM will tell me too. It has the CGI. So
Right.
so it'll never be probably absolutely perfect, but it's like flat line.
Yeah.
So
Yeah.
yeah, and my coronary calcium is 0 still. So for the
Right.
important
And
outcome,
ultimately, that's the holy grail. That
yeah,
CAC
the Holy Grail, I'm
is really
happy.
what this is all about. Yeah. Yeah.
Yeah. So
And you currently work in the VA administration, is that correct?
yeah, so I'm at the VA. So how do I brought this to patients? So, maybe like you, when you had a PhD, so maybe a little more scientific chops than I did, Rob. But, I came back to WVU after the military time, and I kind of I saw things different, right? Like, my state's the most obese state. So kind of one at a time in the hospital, we would start teaching people carbohydrate reduction. That, I did a lot of hospital medicine, and not everyone, I'd say 80% are there for a complication of metabolic disease, right? They're having a cardiac event. They've got a diabetic foot ulcer. They're septic, other than the COPDers who were just smokers. Almost everyone had insulin resistance at the root. So we'd one at a time start teaching this, not do sliding scale insulin in the hospital. And for those of you listening, don't know what that is. So traditional doctors in a hospital will give you 60 grams of carbs at every meal with a side of insulin, right? That's
Yeah.
standard of care. So we actually started doing the opposite. We
That's like
changed
giving you some heroin and then giving you Narcan on the side.
Yes, the toxin and the antidote. So here's the
Yeah.
toxin, here's the antidote, and now it's like, well, that's silly, but it's still happening. So we changed hospital menus. We got 10-gram carb per meal menus, started teaching medical residents, and actually opened up a small clinic for me to do this at West Virginia University. We started publishing some of our data, our inpatient protocols, started to gain some traction, but we got sugar drinks out of the hospital. But unfortunately, in the medical environment that we live in, Rob, this wasn't the more you're doing, the academic work, which you're supposed to be doing in a medical school, the more you're kind of marginalized. Yeah, this was not accepted by, the medical complex, right? So they put sugar drinks back in the hospital. They removed all of our diabetes menus, which were menus not to cause diabetes, right? The
Right.
standard menus.
Well, right. And I think to what extent did the changes you bring clash enough with the so-called best practice guidelines that they were caught between this dichotomy of what ADA and US dietary guidelines recommend and what you were doing? Because there's a clash right there.
Yeah, it is.
And haven't we become a society or a medical society of algorithms and best practices? And if the best practice is wrong, we're screwed. Guys, when I'm just dragging, when I'm struggling, when I've got a bit of brain fog, when I'm feeling a bit down, or when my blood sugar is a little bit elevated because of adrenaline, because I've exercised and it's not coming down adequately, that is pro-inflammatory. And I love my coffee. I like my coffee with my caffeine, but there are times when I want a combination of an anti-inflammatory, I want a combination of some caffeine for that stimulant effect, for that mind cleansing moment that I use throughout the day, and I want to flip myself into deeper ketosis. Well, folks, the guys at HVMN, the Ketone IQ guys, have come up with an incredible product. So think about if ever you use a 5-hour energy, or if you don't like coffee, if you're afraid of coffee, if you have a religious objection to coffee but not to caffeine, Ketone IQ has come out with a caffeine-enriched ketone product. So not only are you getting the ketone bump to help you. If you use this in the morning, if you use this when you're dragging, obviously not before bedtime, this stimulant, the value of ketone IQ with some caffeine in it, is no different than having a cup of coffee, except you're also getting the benefit of ketones. So for those of you adding MCT oil, adding butter for that same effect to your coffee, the bullet coffee, this is basically bullet coffee, except it's directly giving you ketones. Try it and see. Now, everybody's going to give me pushback. Whoa, 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 whoa. If you're drinking coffee, if you're doing MCT oil, if you're doing butter, you're doing exactly this.
Yeah, I mean, it's quality metrics, are what we call RVUs, revenue generating. We're basically, as doctors now, we're like commodities. We're just there and following. And the guidelines are usually single organ subspecialty guidelines. So we're all graded by, how many medications they're on for X condition, driven by the specialty of that organ. And the New York Times last week had an article on polypharmacy. Maybe we could link that. And the first comment, because polypharmacy we know causes harm, but which of the many drugs is it? So the average veteran now is on about 10 medications, right? And they all conflict. And we know together there's harm, but how does that happen? But like for me as a doctor, I'm graded by my medical management of all these organ systems. So, and if I don't do that, it's almost like a soft coercion. Because if I'm not meeting all of these quality metrics, like everyone needs to be on a statin if they have diabetes, right? So there are all these if then, and it takes out critical thinking, and it places doctors in. And the Times also wrote an article on this, Rob, about a year ago. So we're all in kind of this moral quandary where one day you wake up and you go to work and you're not helping people by all of this dehumanizing pseudo productivity, so to speak, right? So we're all, it's dehumanizing. We're there. And that's why I think you read about physician burnout. We're all dehumanized in this system where you have this more, you wake up and it's like, as Prof says, the Damascene moment, right? It's like, why am I here?
Yeah.
And
but what's interesting, Mark? Part of the reason for that is because while we've been trained, I mean, I spent 19 years at medical school, going through fellowships, doing my Ph.D., spent a lot of time in the trenches, learning to think, the majority of folks now taking care of healthcare are not necessarily MDs, maybe have had a significant, and there's no criticism here, it's a system issue, but have had a paucity of physiologic training. It's outcomes metrics, and it's here, if this is the problem, this is what you do. I'll give an example in the VA system, and I'm not poking eyes, everybody's doing the best they can, but I've gone to a couple of states now where the person for the VA hospital that's in charge of diabetes is who? Who prescribes the diabetic medication? And I'll give you an example, the state of Wyoming, VA clinic in the state of Wyoming. Who is the diabetes specialist in the state of Wyoming who prescribes diabetes medication to the vets?
It's probably a pharmacist.
Exactly, it's the pharmacist. Yeah. And I've bumped into that in several state VAs. I mean, it's just, and they're doing the best they can. They come to us and they say, give me your thoughts. How do we manage this? But they're identifying, diagnosing, and prescribing diabetic medication to vets. What snowball's hope is there in hell that these folks are going to understand the ramifications of diabetes? And that's the frustration. So in my own life, what I've done is and I think you and I are a little bit different to this, but I've decided I cannot impact society other than maybe through my YouTube videos. That's why I do this. This has a broader reach. It's a more passive reach, but I can make a difference to individuals when they choose to seek that difference. So I take my practice one patient at a time, and I have to have blinkers on about the rest of the world because I'm not going to solve it.
Yeah, absolutely. And I feel actually very privileged and proud to work at the VA because we are probably the last frontier of a national healthcare system. Right. So even though we're all driven by a lot of these same specialty guidelines that you are on the outside, it infiltrates into really I mean, you could be working for a federally qualified rural health center, which is working with Medicaid, clearly trying to save resources. Mm-hmm. But I think as clinicians, we're still kind of held to these. And I think you've spoken with some of your talks, so medicine is very authoritative, meaning so we're rule followers. That's how we've trained the long white coat, right? So that we're trained to follow authority no matter what system you're in. So, I hope before I retire, we can change things, in my institution, one person at a time, because we're gathering data. We want people to understand their disease. We give them permission that they can get out of their disease, and try to stay within the guidelines and rules we have. But, we'll catch up in a year to see how. I've been there a year now, and I presented some of our early data in January this year in Boca, and we're seeing like 10 to 15 pound weight loss at first follow up, which is good. It's better than any VA program, and that's without coaches or extra people helping. They just come in, and they don't come in for a weight loss clinic. I'm just their GP, so they come in thinking, well, I'm just going to refill all their meds. They're not I'm not a referral. So you're taking someone who has no idea we're going to talk about this, and you bring up insulin. You have insulin resistance, and they look at you like you have two heads. And
Right.
then, before you know it, you're an hour behind in your schedule. But that's okay, because I think people deserve to understand their condition. If they don't understand their condition, they'll never get out of
But
their condition.
isn't that part of the challenge, Mark? And I think this is also where your practice and my practice differs. My entire practice is self-referral. So everybody that walks through my door wants to be there, and they want
Absolutely.
to be there for what I do for a living. That's what makes it so beautiful and so wonderful. And I'll die in this chair at some point. With you, you have to take somebody who you maybe go up to somebody and say, "That's disgusting. Why do you smoke?" And they're rah, 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 rah. Whereas I get people who say, "Look, I really want to quit smoking. Please help me." There's a big difference. So our starting point is very, very different. You're spending a lot of time, and that's what's so commendable about the kind of weight loss you're seeing. You're starting with somebody that's completely pre-contemplative of the notion that they're even sick in a metabolic way, or they don't understand it. My patients are so darn educated. They come in there having the biohackers, especially, so much literature, so
Yeah,
much
they've already watched your YouTube
and
videos. See, I
right.
wish
And
I
so
wish
all
I
I'm, yeah.
had that
And my
privilege.
job with them is to reinforce what they're doing well and maybe alter a few things based on their blood work. That's easy work for me. I mean, it's highbrow, but it's easy. You have the toughest challenge of taking somebody who doesn't really want to change and helping them to understand why, and then guiding them in the methodology. So kudos to what you're doing. But that's the challenge in society, is my patients are referring themselves. They want to know, they want their blood work reviewed, and we figure out ways to do that. And along those lines, so I appreciate that as an introduction. But one of the reasons why we set this visit up is because we communicate in a quiet little club between each other. And along those lines, one of the things that we've seen a lot of is the massive rise in the last 3 to 5 years of the indiscriminate use of GLP-1 medications, Ozempic, Mounjaro, this massive industry that's gone up like crazy. And we're seeing doctors writing these scripts as probably the number one or number two scripts, maybe after statins, that they're writing for conditions. But they're being very passive about how they write the script. Here's your script, off you go and be skinny. And I understand that they're dealing with folks who want to lose weight, but don't understand why. They want to treat their diet, but they don't understand why. Very similar to the patients that you see in your office, and then you have to spend an hour or so, a long time, trying to educate them. We obviously are using GLP-1s as ancillary devices, but isn't that part of the problem, is that everybody's using GLP-1s, but there's probably more of them going out the back door of the pharmacy than the front door by prescription. And everybody's using these drugs to lose weight, but nobody really understands what they're doing. So they've got a tarnished reputation amongst folks like yourself, whereas I'm very, very gung-ho about these drugs. Only drug I know that treats insulin resistance, but when used appropriately. So along those lines, do you use GLP-1s at all? And if you do, or if you don't, what are the indications for use, and what are the contraindications for use?
Yeah, it's a great question. I'll back up to my former practice. I was at a Center for Diabetes and Metabolic Health. So I dealt a lot with patients like at WVU at the clinic. A lot of these patients were referred by other providers for metabolic health, obesity, diabetes, and this was the early days of semaglutide. So we used to have sample pens in the refrigerator, right? You could, now the street value of that's like crazy, right? So we would use those, similar maybe in some ways to you, Robert. These were the worst insulin resistance patients we had. So we'd have patients come in on 2, 3, 500 units of insulin a day, and with high insulin states, you can never reverse insulin resistance, right? Because like you got to get the total insulin load down. So with those folks, with aggressive dietary management, we would pull out a sample pen. It wouldn't be on first visit. Usually we'd see how they did, educate them, see if we can drop their insulin without the med. They were pretty new at the time, but then it would be like second visit. We were pretty quick to pull out for those folks on big insulin doses, high A1Cs, already have stents in their heart. Okay, here's the sample pen, 0.25. We would show them how to do it, inject the first dose, talk about the nausea, a little bit about, we understood about the thyroid cancer risk, but it was more about nausea, right? And we'd see them back at that 6-week mark because it was like a 0.25 for 4 weeks starter pack, and then 0.5, 1 pen. And then we'd see how they were doing. And we saw a lot of people with remarkable effects of those meds, right? We had CGMs on a lot of them, and we were able to lower the insulin. And most of these never got insulin to zero. These are like people on big, long-acting doses. But if we could get their insulin down into a physiologic range, maybe 10, 20 units of long-acting twice a day, they'd start to lose weight and they'd feel better. But the goal was never to crank the dose up, right? So rarely did I ever get anyone above 0.5, maybe to 1. And for those listening that don't know the dosing of these, so when they're marketed as an obesity med, the marketing is kind of different, at least in the real world, how they're being used. The goal is keep cranking the dose up to 2.4, because then there's a lot, most people will get side effect way before that, right? They don't want to eat, which is probably a highly effective way to help people lose weight.
Right.
They
and
don't
also
want to eat.
collect diabetes. I mean, if you to collect the type 2 or the insulin resistant component, you don't eat, it gets better. Jason.
Yeah. And I think the food addiction was actually important too, because, I didn't have a blood test that could tell me who was food addicted, but you got a sense after several visits and how they responded to the GLP-1s, which people had a component of that. So yeah, I found them to be very effective in that group of patients. And this is before they even became weight loss drugs. And we were using them. We had samples. And they were even like, Eli Lilly or Novo Nordisk with semaglutide. They had a $25 coupon. So these people could get this med for $25 for like a year, right? And so to me, it seemed like, a net positive, right? So, and we even wrote an article on medication. It was published in Frontiers 2021, medication reduction with low carbohydrate diets. And the GLP-1s were a green light drug, right?
Let me stop for a second there. Isn't that what you just said there? You just glossed over that. But that's the difference. GLP-1s with a low carbohydrate diet. For most people, it's just GLP-1s as another, the average endocrinologist is just writing drug after drug after drug, and off you go and manage your diabetes. Drugs don't manage diabetes. You mentioned the word low carb, so you've given them ancillary guidance along that way. But nobody comes off their blood pressure medication if they're just taking medication. You don't fix blood pressure. You don't fix diabetes with medication.
Yeah, absolutely. Yeah, so the VA actually, so things are a little different now. So again, like I moved my practice before these medications started kind of going, popular media haywire. And part of the reason I think just led me to find a change in practice was, early these were diabetes drugs, right? We didn't use them for obesity. And certainly we used low carb diets, right, as foundation.
Let me stop you for a second, because I've got some intimate knowledge of this, in that you and I understand this to be the indication by the FDA was originally for diabetes. But when you talk to the people that produce these drugs, a very close friend of mine is the head of Eli Lilly diabetes section in the UK, a classmate of mine. And their entrenched belief is still that diabetes is a consequence of obesity. And therefore, if you lose weight, your diabetes gets better, which observationally is 100% true. Okay. When you lose weight, your diabetes gets better. Bariatric surgery, whatever it is, that's true. But they are not causal, they're associations. And the challenge is that the observation is so obvious that that is the mechanistic thing that they understand. It's not insulin resistance, whether you're obese or diabetic, is kind of a similar disease. And what you're treating here is the insulin resistance. They truly believe that obesity causes diabetes. And if you treat obesity, you get rid of the diabetes. So they still believe that the GLP-1s treat obesity, and that's why diabetes gets better. That is still an entrenched belief with both of these two companies that produce it. And you and I know differently. Not
Yeah,
in an
we don't
arrogant way,
measure the
but
hormone, I mean, we don't measure, whether you're pre-diabetes, diabetes, obesity, the hormone of interest is insulin. So what endocrine disorder are we treating it with more of that endocrine substance without measuring what that endocrine level is, right? So, we all have a hypothesis, and then like you measure insulin levels, right? So you just, tomorrow I'm meeting a child, one of our study subjects from a year ago had fasting insulin of 90, when we enrolled her, like, and for those of you listening, normal would be like 5, right? And this girl was, quote, not diabetic, right? It's like, no, she was 300 pounds in 8th grade. No, she's fully diabetic, right? Like,
well, so I would call her obesogenic. In other words,
yes,
she can produce so much insulin that she can clear the sugar from her bloodstream.
yeah,
When you peak out and your insulin resistance is beyond your ability to produce insulin, then you become diabetic. So
yeah,
both are states of hyperglycemia, but one is
nice.
hyperinsulinemia. One is insulin dominant, the other one is glucose dominant. And I've actually created a separate pathway for those two diseases because
Mm-hmm.
there are people that cannot produce that amount of insulin. They
Yeah,
genetically
they'll never become that obese, right? There,
right, and right. So they can't become obese. They can't get the sugar into their fat cells, but they develop diabetes because the sugar hangs around in their bloodstream. Whereas someone like myself, my peak insulin production was 87 fasting insulin,
wow,
and
yeah.
I
So
was
you're like
300 pounds. Okay, now
300
I'm at
pounds.
3 to 4, as you said. So, you show me a donut, and I'm going to gain 5 pounds. Whereas you show somebody else a donut, they don't gain any weight, but their blood sugar goes up by 50 points.
Yeah, you and I are opposite because people kind of like maybe they're a little jealous of me because my C peptide's 0.3. Like I make
Right.
almost no insulin, and I cannot gain weight. Like I cannot. But I could eat myself into diabetes really quick with a couple meals, but not gain weight
Yeah, I
because the
can put you on
glucose
insulin
just
and feed
goes
you
right into.
carbohydrates and I'll get you to gain weight.
Yeah. If I went on long acting in, but everything stays okay where I am now. And if
Yeah.
I wanted to eat more carbs, I would take basal insulin
Well,
at
that's
probably.
also why your A1C is 5.5, 5.6, not 5.2, is because you can't clear that extra sugar because of that low
Even
insulin.
from the protein, even
Yeah.
the little
So that's
veggies.
and protein doesn't trigger insulin, which is an interesting concept that we've kind of discovered along with Ben Bickman, is that it requires GLP-1 to trigger the release of insulin. So that was an experiment that failed, the modified protein sparing diet, where we used lean protein to see if we could trigger insulin, and we failed. And we failed because GLP-1 wasn't being triggered in the gut.
So the
Natural
protein
GLP-1.
is not triggering any insulin from what you've observed.
Very, very little. Very, very
Yeah,
little. So
the,
when
the
we do a
ones need
craft
to
test,
cover it a little bit sometimes. The
yeah,
type
yeah.
ones.
You can
They.
do a craft test, but on a lean protein diet, they still stay craft 5, the LMHRs, the lean mass hyperresponders. Whereas if you trigger GLP-1 with sugar, eventually they start mounting an insulin response if they can. But back to the GLP-1. So you were comfortable using them. Is your opposition to them? And I'm again in our discussions online, I've noticed a degree of oppositionalism. Is that because of the ubiquitous use of this as an instant weight loss drug? It's just another phentermine, or what is your opposition to the use of
Yeah,
GLP?
and I would say it's a great question. I'm not like binarily opposed or for them. I'll put patients at my current job. I have to fill out a prior authorization. I'm opposed to the way they're being marketed now, and I'm opposed to the way the studies are designed, funded, thought leaders. So I'm an obesity medicine certified doc, and I had to take 60 hours of coursework by the thought leaders And at the time, this was really before I did my certification over 2 years ago. And I pull up all the slides now, funded. So all the thought leaders, and it was that's what was we could share it. There's an article. It was in Forbes, I think. So the thought leaders in the obesity medicine, and that's why I'm glad I'm in the Society of Metabolic Health, right? So I don't have any it was the amount of money, Fatima Cody Sanford on 60 Minutes saying obesity is a genetic disease that needs aggressive medical treatment at very young age. These people are making more than, maybe not you, me, I'm a GP, way more than me, direct money from pharma. It's insane how much the thought leaders are funded by. So everything is skewed. The data on the trials are not the real world.
I'm sorry, I'm going to interrupt you for a second. There's no on God's earth that the word thought leader applies to them. They are megaphones because thought is not involved. They're amplifying
it's
narrative, okay? They're megaphones.
I'm using that term thought leader with parentheses, but if you're a young doctor, and want to pass your obesity medicine boards, you have to, and it was pretty insane. And I smelled a rat, right? And I'm like, what the hell? Because, they come on for these lectures, next generation drugs, game changer. This is third stage of medical, this is a medical, I'm like this, not a single lecture on ketogenic diets and the whole Obesity Medicine Association. It's kind of mentioned, here's your dietary, free liberty of options, right? I'm pro-choice for what people want to eat, right? Of course we are. We inform people. I'm not telling everyone what they should do, but it was a megaphone.
Choice about people who smoke?
Well, no, yeah. They can smoke. It's America. I try to encourage them not to, but right. I have veterans who smoke, and I'll gently suggest, I'll offer them help, right? If you want, Nick, see what is, we always have a conversation. Some are ready, some aren't ready. Right. Some are going through their fourth divorce, have 6 child care payments, lost their job.
And that's exactly, working the carbon.
Yeah, they're not ready yet. They're
right.
addicted.
So, and the same is true for the
they have free choice.
Diabetics and the obesities. Yeah.
Do harm.
So along those lines, though, what do you believe are contraindications for the use of GLP-1s?
I think lack of education about why they would need it to begin with. Yes. Right. So why are you needing? And then they don't have knowledge, at least from what I've witnessed, because I inherited some patients on these meds. Right. So when you come into a practice, you inherit people on the meds. And most of them have no idea what GLP-1 is, where it comes from, how to create natural GLP-1, right? So our GLP-1 is not a pharmaceutical product. It's made by the L cells of our gut and, high protein, even some non-starchy veg fiber. So we make GLP-1, so they're basically taking, a hormonal product, without understanding what that is. It's like a lot of the veterans, Rob, and certainly on the real world too. Now, like you and me could probably get on the phone and get testosterone sent in the mail. So poor sleep and visceral fat. So all these things travel together. Sleep apnea. You
can now buy GLP-1s through these same
things. Yeah. So why is your T low, right? Yeah. And I always ask people, do you know why your T is low? And I have a nice handout. And it's like a checklist. Yeah, your sleep is jacked up, check. You got fat in your belly, check. You're eating, low protein, check. You're not getting natural fat.
Insulin blocks steroid hormone production. Insulin blocks testosterone. So, once you understand those pathways, you understand that. But, the major issues for me, I think, along these lines with GLP-1s is, number one, the biggest complication of GLP-1s is failure after you stop. In the step 1 through 4 trials, the number of people, I think it was like 96% of these patients after 48 weeks after stopping the medication had regained back a substantial amount of their weight. They lost 17 pounds, and at 48 weeks, they'd regained 10 of those 17%. So it just becomes—
And the muscle mass too. I think the step trials, it was like 30 to 40%.
Right, but the muscle mass is an educational thing. The muscle mass, the GI effects are less a side effect of the drug and more a side effect of the awful diet that they continue to eat. So if you're eating salad and Oreo cookies, Where the devil is your body supposed to get protein from? And if you're eating less and your body needs protein, it's going to mobilize its own muscles. So if I do use GLP-1s, I try to lean my patients heavily toward a carnivore diet or a higher fat carnivore-based diet, and they don't have the muscle wasting. They also, if they're eating a decent amount of fat, don't have the GI upset. So those are side effects of the bad diet, and that's my concern is, here you go, off you go, here's your script. Let me ask you another question along those lines. Oh, and by the way, I never use high dose. And the reason, if you need a high dose, it's because you're not changing anything.
Yeah, it's good to hear that, because
Right.
I think that's a critical thing for your listeners. Like, if you haven't fixed yourself with a low dose of this, you need more help, right? We need
Because
to,
what happens is you become drug resistant. So all these
yeah,
people taking the drug and they say, oh, it's no longer working. Then they jack the dose up. Now you're getting pancreatitis, which is a real side effect of the drug when it's high doses. And we see that. And also, they become resistant to GLP-1. Just like you become resistant to insulin, you become resistant to GLP-1. And then you start to gain the weight back while you're on this drug. So there are challenges. One other
I want
question.
to pause you 1 second there for something
Yeah.
almost comical in what you talked about with the nutrition. There's a buck to be made everywhere, Rob. So just today in CNN, so GNC, General Nutrition Center, I guess they're struggling. So they have a whole aisle now on food supplement if you're on GLP-1. So now GNC is they have the Ozempic aisle of protein shakes. And I'm like, and Oprah was on the article, and I'm just like, it is the apocalypse.
Yeah.
That now Oprah is advertising for GNC for protein shakes because all these people are on GLP-1s.
But
Like,
let me
what?
show you something. That, I don't know if you can see this, that list, that's a list of experimental drugs that are currently in testing and production to stop the muscle wasting of GLP-1s. There's a whole host
Yeah,
of
the
these
Times
drugs.
had an article on that. It was
Yeah,
crazy, right? It's
I'm on
the arms race.
yeah, I give some guidance to venture capital and that kind of thing, but we've got all these names, and then we've got the amylins and the new triple G from, so all these massively revenue producing drugs are in production, and it's not to better humanity, it's to make money. So I have a major issue with that. Um, the other question I have for you, though, one of the benefits that we do see from GLP-1s is their broad ability at a central level to manage other forms of abusive or addictive behavior. Have you noticed that in your vets at all, the smokers, that kind of thing, that they are seeing an improvement in other addictions?
Yeah, have so few on these meds, Rob, that I wouldn't know. But when I was using them more, kind of as you were, my last practice, when we had samples that I could give out from the fridge in the back, yeah, I mean, I don't have data because I wasn't really measuring it, but I did notice that the food addicted, but I didn't really cross it over. I know people are using it now for opiates, smoking, but I think there's probably way less expensive ways to do it.
They are.
If we could, if these were metformin price, I think all of us would be, using low dose, probably like super early on in diabetes, right? Like if like 0.25, zero point 0.5, like low dose, deal with that food addiction primarily, even before metformin. I think if I had these available for $5 a month, yeah, and then
Well,
teach them the
that's
diet
what it
and
costs to produce them, by the way.
I know it's
$4 a month. Okay. So
you can get it in Germany. What's the even the retail price in Germany is like $140 a month, something like
yeah,
that.
it's dirt cheap. So let me
Incredible.
ask you this question. Do you treat hypertension?
Oh, absolutely.
What are your medications for hypertension? Well, what is, somebody comes in, you check their blood pressure as a wellness check, and it's 160 over 95 or 100.
Yeah.
What do you
So
do?
for one, I never rely on a one blood pressure in the clinic. They all have insulin resistance unless they're heavy smokers. They've got stiff blood vessels. So usually it's a and they have erectile dysfunction too, 100% across the board. So
Right.
it's a conversation to help them understand they probably have cardiovascular disease, and they better figure out what's triggering that. Are they smoking? Are they diabetic? So my first line treatment for that is nutritional, right? Lower the hyperinsulinemic state, which causes sodium and water retention, inflammation, stiffens blood vessels. But when we do need meds, I'll usually start with an ACE inhibitor or ARB. They're probably the most friendly side effect profile. and they have probably the most data for heart failure and kidney protection in the diabetics. So, but I don't like titrating more and more meds in, because you see a blunted effect once they're on like 2 or 3 blood pressure meds and they're not having a response. That usually means they just have hard arteries, right?
Right.
It's almost what we call pseudo hypertension, where the cuff is pushing on the artery. It's not measuring the pressure in the artery. So we'll see people with these crazy high blood pressures and they're sitting there chatting with you. It's not real. It'll be like
Oh, because
220 over
it's also
100.
insidious. They've gotten used to it. It didn't just happen yesterday.
Yeah.
So the question, so you've got a set series of antihypertensive drugs that are all related to calcium channels and ACE inhibitors and a variety of, they slow down heart rate contractility. So they all act on the blood vessels. How many of those patients that you put on medications have you taken off because they didn't need them anymore?
Oh, several, right? So I'll send, if they've been on multiple meds, send them home with a cuff. And so I have a database of all my Med-S syndrome patients. There's about 550, maybe almost 600 now, out of a panel of like 1,100, 1,200. So your audience knows criteria for Med. So over half of my patient population is unwell, right? They're metabolically sick. Oh yeah, so the diuretics get off really quick, because if they go out and they actually say, I think I'm going to do this, carnivorous low carb diet, we stop a diuretic day 1.
So let
Because
me stop you for a second. So just let me make sure. So when you see a new patient with hypertension, you start them on medication, or you potentially start them on medication, but you also have a conversation about a low carbohydrate diet. Is that reasonable to say?
Yeah, if they're insulin resistant, other than the smoker. So I'll occasionally see a
Let's take
smoker.
let's take smoke out of the equation. So
yeah.
how many patients have essential hypertension that do not have metabolic hypertension?
I probably haven't seen it. And I don't think I even send a message up the chain. There's this like, there is no such thing as essential hypertension. Like, I'm like, what does that mean? It's essential. It's never, or there's another
essential hypertension is a smart way of saying we don't know what the hell it is.
Yeah, we don't know what it is.
Right. But the point is, most
term.
people are diagnosed with essential hypertension. Right. And it's almost
Well,
always
sleep apnea is one that I think, sometimes I'll have a sleep apnea patient who actually is metabolically pretty damn well, but they just have horrible sleep apnea. And, there's probably multiple mechanisms to that.
Like that may be central sleep apnea as well, or a mixture.
Yeah. And some of them just do have obstructive sleep apnea, even with normal BMIs, trigs below 100. They're kind of outliers. But
let's come back to the blood pressure, because my first line of drugs now for hypertension, as long as I've excluded all the bizarre things, the renal artery stenosis, is a GLP-1, because it treats together with a low carbohydrate diet, and I use it transitionally for about 3 months, and then I can when their hypertension is normal, when it normalizes 110/70, 120/80, I can then deprescribe that medication at about 2 to 3 months. Whereas it's very, very seldom that you have a similar effect with the vascular antihypertensive drugs. So it's just been.
Yeah, I would agree with you. If it was $5 on my formulary and I was allowed to use it for that, I probably would.
Right.
But the restrictions in place, whether you work for federal or you work for, insurance companies, right? Like, but maybe one day, you say they do cost like nothing. And when these things are generic and, we have more long-term data, I think we need data, right?
Well, I think the data's out there. It just hasn't been, and we're going to talk about that in a second. The data is almost impossible to publish for 2 reasons. Number one, the story is unbelievable, so you're not going to get through peer review. But we were talking about this a few minutes ago, and that is how difficult it is. Everyone says, oh, well, you should publish this. You should do the study. You've done that. There's a beautiful, beautiful paper that you and Jeff Volek and Steve Finney and a few others have published, and it's the expert consensus on nutrition and low carbohydrate diets. And I'm going to put this in the show notes. And then you're about to publish a great couple of papers on childhood obesity. How difficult has that been?
Difficult. Yeah. So it's approved for, probably will be public in a week. So we have a 10,000 word 2-part article on pediatric obesity, with insulin resistance as the root cause and low carb. So part 1 is, is over fat in children, right? So like we need to reframe, what we call it, right? So it's ectopic fat, and so it's reframing what it is and what's the root cause, insulin resistance. And then the second part is a practical approach to reversal, which is a low carb diet. So that is 2-part article, 10,000 words. That's been about a year, with co-authors James Bales from Marshall, Jenny Favret from Duke, Anna Bradley and Nina Padu from Vanderbilt. So we have multiple institutions on this article. But to get something that's different through the peer review pipeline is a long. So you're talking about, you got this idea for an article, you start putting it together, in a year, right? Maybe 6 months, you've got a first draft, you throw it out to a couple places for review, then you're okay, let's try to publish it in this journal. There's 4 reviewers, and all of them have different ideas. It goes back and forth, and you have to reformat it, and all of us who are doing this, we don't do this for a living, right? We're doing this just to do it at, on weekends and evenings. And anyone who writes knows that you have to clear your headspace for a significant chunk of time if you're really going to write, really do a thorough review, when you have to actually respond to the comments. You can't just do it between patients. You're like, okay, I need to block like 4 hours this weekend and actually sit down and go through this line by line again. And then, but yeah, so but I think at the end of the day,
publish as well. You got to pay to publish.
I'm sorry?
You got to pay to play as well. There's cost involved. And unless somebody else is paying for it, there's quite exorbitant costs.
Yeah, to get this pub open access, it'll either be behind a paywall or behind an academic library, or if I can come up with $5,000, I can get it. So I just want to get it out the door, and then I'll see later if I can come up with the money to make it open access. But the first goal is just get it approved, get it.
Those are the challenges. So when anybody out there, the audience says, "Oh, publish," there are huge barriers. And I will tell you this, Mark, is that the cost involved to publish is a big deal. So if anybody out there is saying publish, and you've got a little spare change, throw that at Mark to help him to make that. I've reviewed that obesity paper. Mark was courteous enough to allow me to see the draft. It is phenomenal. And I want to explore it a little bit with you. But if there's anybody out there that'll sponsor the publication of that paper, throw some money at Mark as a tag to be able to make this open access, because Mark's going to publish this brilliant thing and nobody's going to be able to read it in the lay public unless you've got behind the wall access. But it costs about $5,000 to give you open access to that paper. So that's a plug. Again, if you're willing to accept that.
And that's why, like, all the pharma papers get published. You $5,000 to Eli Lilly. Oh my gosh, that's toilet paper, right?
That's 3 months worth of Manjaro that they've.
yeah. You think about that. You're like, no. You're like, why do all these? They own the journals, right? So to get a paper published that actually goes against medications for the most part, like the root cause. I mean, we actually talk about meds in the article. We're not against them, but we're like, the root cause is insulin resistance, and the first line of attack is low carb diet, right? And meds are add-ons, and bariatric surgery, right? There are considerations for that, for the right patient, done correctly with the right support. No, we're not.
But that's an end option. It's not a first.
Absolutely. Yes.
And that's the big difference is, oh, I'm fat, I need surgery. I'm fat, I need a GLP-1. No, that is the end. Let's put it on the table, but do your level best to avoid using the medication, to avoid the surgery. That's the approach that we use. But I want to explore because I love what you did with the obese children, but I think there's a transformation in thinking. And obviously I work in the child space. I'm a board certified pediatric surgeon, and I've got a 3-year-old, and I watch what's happening at their schools. And I just want to share that. I'm going to do a little bit of talking, Mark, but I see 3 sets of children, and I've stolen this, but it's a phrase that I've implemented in my own thinking. I don't think anymore of obese children, or the phrase that I use for that whole symptom complex is neurometabolic disease. Neurometabolic disease, which I'm a carb addiction doc, which combines the brain, the psychology, as well as the metabolic disease. And the expression in children, I see the expression in 3 different categories of kids. The obvious visible ones are the obese kids. everybody can see an obese child. The more subtle expression, and I think the undercalled expression, is in our autism spectrum disorder ADHD population. But they're still testable around the age of 8. CDC says it's 1 in 32 kids now have ASD. And that is a neurometabolic disease. The third one is the invisible one. And the third one, and I guess I'd be the obese kid, you would be the one I'm talking about right now, which is what I call the skinny kid. And there are plenty of kids out there who 80-90% of their caloric consumption is sugar and starch. And when you look at them, they all look lean. They look healthy by appearance. But when you hold their arm, when you hold their bodies, all you feel is skin and bone. There's no muscle. They're not eating adequate protein to support muscle. They're insulin resistant, moderately so, not to the point that they are producing massive amounts of insulin to become obese. So they can't gain that weight. They can't triage that protein to muscle. And they are as metabolically, if not more metabolically unhealthy than those obese kids who at least are turning the sugar into fat. And there's a huge cohort of these kids that look fabulous, that may be able to function well, but they already, in the first decade of their lives, have profound neurometabolic disease. And so I look at that entire spectrum of kids as being a generation of extremely metabolically challenged kids that are going to be 2 to 3 decades along in their disease process by the time they're in their late 20s and early 30s.
It's going to be hard to reverse then. Yeah, absolutely. Yeah.
We're not going to reverse that, but I think there are so many kids that look so healthy, but when you watch what they're eating, when you look at what they're eating, there's very little difference between what the obese child is eating and what the skinny neurometabolically diseased child is eating. No difference. Just like if you take 2 pasture-raised cows and they eat exactly the same grass, and one cow is this angular, miserable-looking cow with this massive udder because all their energy is going to milk, and the other one is this big Angus cow that is big and muscular. They've eaten exactly the same food, and yet the expression is completely different.
Yeah, no, I think we even shared. That's why, you asked me, would you recommend, an animal heavy diet for an otherwise well kid or a skinny kid like myself, right? Of course, right? It's going to help me stay well, right? But we all have different issues, but it's the, Ken Berry, right? This is the proper human diet.
Mm-hmm. So, yeah, I mean, but I think that, while
no matter what your issue is or non-issue, right? Like if you're well, you want to stay well, just eat proper.
Exactly right. But that paper sheds a light on the obesogenic side, but the other 2 groups are kind of left behind. Nobody touches the autistic kids because it's so politically sensitive and it's so controversial. It's so, I guess, politically sensitive. And in the skinny kids, nobody sees them. Nobody sees them other than being healthy. But if you watch what they're eating, I'm obviously very passionate about that. Any role in your practice for statins or lipid-lowering drugs?
Yeah, so I think, I'll look at the data, and I think if someone has hardware in their heart, they have stents in their heart, and probably that patient, it's, even you listen to David Diamond's lecture, you probably have to treat 50 of them to help one, but that as long as they're not having complications. So I'll use statin in those cardiovascular patients, but I'll use as a triage for people with, quote, high cholesterol. I've pulled many off statins through the use of coronary artery calcium. So if they're my age, they're in their 50s and they've been on a statin, but they're otherwise well, and I'm like, well, would you like to consider coming off the statin? And they're like, oh yeah, like let's do the test, right? Why are you on the statin?
Okay, so what is the test? Because there's 2 different tests you can do for coronary artery vascular disease. You can look at LDL, cholesterol, ApoB proteins,
whatever, right? Or you can look at the arteries.
You can look at the arteries.
Look at the arteries.
We're not treating numbers, we're treating our vessels.
Yeah, so I see a lot of metabolically well patients, right? So they have high LDL, but their triglycerides are 80 and their HDL is 80, and they're not on blood pressure med. They don't have a lot of visceral fat, and they've been on statins for years, and we'll talk about that, right? So I try to deprescribe with every patient I see, That's, in medical school, we learn to prescribe in our authoritative type of training model, right? We prescribe, right? So people are open to deprescription, and we do that. And it's a $99 test, and we can get the test. And, most choose to do it because they kind of want to know, and if they're a 0 score and they're 60 years old and otherwise well, have a nice life, stop your statin. There's no data, but I've seen some really fascinating stuff though, because we don't know, right? So I've seen people I thought, oh, they're going to probably be pretty good. They'll have scored like 2,000, right? It's like, whoa, this is different, right? Then that person may need aggressive lipid lowering as well as, treat their diet. I mean, they have 30 holes in the roof, right? You got to nail everything in those people because their runway of cardiovascular disease is a very fast runway, and they're heading to the end. If you're 50 years old and you have a score of 2,000, for those listening, that means you've got a ton of plaque in your arteries, and plaque rupture is
score is 0. So let me ask you this: do you order CAC scores?
Yeah, I do in those type of situations where it can change our management.
Are you allowed to order them as a family practice?
Yes, yeah, I am. It's an outsourced service for veterans, so they do it in the community because you have to go to a facility that does a lot of them. And I think in a year we just hired a cardiovascular radiologist. So you have to have someone in your building who actually knows how to do that test. You have to have the right equipment. So we have a few centers, within a 30 to 50 mile radius that are high quality centers that the FAA uses, military use. So we have good centers for calcium scores. Just like if you're a female and you get a mammogram, you want to go to some place that does a lot of mammograms, right? You want to go to a very good center, because there's a lot of non-human brain involved in these tests, right? They're quantitative, and I like that. This gives a quantitative
software algorithms. I mean, you buy a software package, you slap it on your CT scanner, and
it can pick things out, that my brain wouldn't pick out. So yeah, we use them, and I think, I kind of like, threw a little wrench in because I was probably the first one to even order them at my facility because they didn't know what this test was.
Right. Statins are the most commonly prescribed chronic medication in healthcare right now. They're number one. And the question is, how many doctors that prescribe statins ever do a CAC score? And as you said, if you've got a 0 CAC score, maybe you don't need that statin.
Yeah, it's in the Mitchell studies, right? Because your odds of a plaque rupture, and now the caveat to that too is, so, if you're a 45-year-old diabetes patient, Kerm Nasir's article kind of showed this. So the diabetes patients should not get a false sense of assurance with a 0 score at age 45, right? Because their conversion to a non-0 score is actually over 5 years, pretty significant. So we don't want to.
What I find is if they've got a diabetic with a 0 score that is not very tightly managed with an A1C of 5.253, they often have neuropathy. They often have ligament. In other words,
they have other issues.
Interstitial disease as opposed to vascular disease. So I look at both of those, and I look at the electrical system as well as the plumbing system simultaneously. But you and I are talking very comfortably about CAC scores. I got a letter from a doctor at Kaiser who said that it is where is that letter? It was amazing. I sent a patient. I said, please get a CAC score. She was a Kaiser patient. The doctor wrote back. The family doctor said, it is not indicated to order a CAC score because you are asymptomatic. You don't have any chest pain. You're asymptomatic. Right? So the patient went along, got her own CAC score, and it was 2,000.
Jeez,
She ended up requiring stents at first, 3 stents. So, I've actually got
the only test we used for military pilots. So you could respectfully reply back, well, this is the only test that is approved for military pilots to quantify risk, because I was a flight doc, right? Military pilots look at data, and the only test that would give us enough data that would say someone has less than 1% chance per year of a cardiac event, because those people can fly performance planes. If they weren't CAC 0, no performance planes. So because now NASA doesn't let anyone fly up into space who has a score greater than 0, because there's, because you're dealing with, a very high stress situation, right? So that doesn't mean that, if you or me have a score greater than 0, we can't go play golf. But but that just tells you the power of 0 to de-risk. The term is de-risking, right? So people are walking around. Every doctor you see, you're afraid you're going to drop dead of a heart attack. other than the one you just mentioned, which is telling your patient who is going to drop dead
But
that they're well. Right? So
the patient was fit to exercise.
yeah, they think, oh, you're
And
well.
that's the
No,
problem. They judge they will send the fat person for that score,
but not healthy.
but
You know,
not the healthy person.
yeah, fit but not healthy is too common.
So who do you follow on the internet in the ketogenic space? Who list 4 or 5 people that you truly look to for guidance that are online that the folks, my audience, can just click a button and see on YouTube, see on Instagram. Who do you believe has it right? Who do you follow for guidance in this ketogenic space?
Yes, I got it. Maybe a few buckets. So I look at the true scientists, right? Because I love them because, so Ben Bickman, right? He's brilliant. And he's the guy doing, he starts with mice and now he's moving on to humans, right? But, I think he explains the physiology, and deep dives into his book, Why We Get Sick, is brilliant. Then I'm a GP, so I just look at real world people. So like David Unwin, give him a hug every time you see him.
David Unwin's in the UK. He's a GP
in the UK. So he's like low carb GP in the UK. So he's doing what I'm doing, is just in a regular busy GP clinic, trying to change people's lives. Then I look at, I love the people that are just preeminent writers, so Nina Teitschultz and Gary Taubes, their Substack and every single book. So Gary, I think all of us in this space, owe a debt of gratitude to Gary Taubes for writing Rethinking Diabetes. Geez, that book is a tome, the history of diabetes, right? Let every doctor read that, because he has like 3 chapters on bad science, right? Mm-hmm. So we need to understand science. So, and Nina, of course, she's brilliant and she just got her doctorate. And, 10 years ago, she wrote Big Fat Surprise, but she's constantly, and I'm with Nina on the Nutrition Coalition, and Finney and Volek, right? They were the early scientists and clinicians in this space. Dr. Tro, right? He's a good friend. So he's in the real world, like you, a lot of people are self-referred to him. So his data is going to be different than like mine are like all comers who have no idea we're talking about this. So, and then I go to, like you, I go to the conferences and I learned something. Georgia Ede, I just read her book, mm-hmm. Chris Palmer, Michael Eads. I learned from everyone who's on that stage, as well as people in the audience, because we learn from the people. And people come up to you and, they're like, yeah, I did, this, thank you, or listen to you on a podcast. And this worked, because that, I think we can all listen to all the lecturers and thought leaders, so to speak, right? But it's the people on the street, it's just a bunch of lectures from thought leaders, and maybe we're all full of it too. But when you see at the low carb conferences, half of the people in the audience are people, they're not doctors. Right. They somehow got their life back and they're just curious. And I've never see that at, American Academy of Family Physician Conference. Like say you went to your Bariatric Surgery Society. So if I went to the AAFP conference or the Obesity Medicine Association conference, there's not a single patient in the audience.
Yeah, there really is 2 types of people at most of those conferences, just like with dietitians. They're either obese themselves and don't know why, or they've never been obese, so they can't really give kind of that lifestyle advice. The folks that have walked this walk, that are still walking it, that have had a tough time, they can give you good guidance about their story. But the reason I ask you that question is that I separate out 2 groups of people, and there are very learned people on both sides. But there are people out there, like the folks you just mentioned, who are third-partying their information. In other words, they make it about the data, about the information, about, I love the word you used, physiology. And then there's a whole group of people that tell you to do what I do. I did this, therefore you should do this as well. And they try to cast you in their own image. And I can assure you that I am not them in my own life. So as a patient, I try to stay away from those folks that try to I'll listen to them, I'll hear what they have to say, but I'm not going to follow somebody who's trying to cast me in their image, because I am not them. But if you listen to a Ben Bickman, even a Ken Berry out there, who's giving third-party guidance, that it doesn't matter who you are, you can fit into that information. That's an important consideration for me. And all too often, people get trapped into the personality of the person that's speaking. And there's several people that, oh, I'm doing this, I'm carnivore, or I'm keto, or I'm eating carbohydrates, and they follow those people because they look pretty on the internet, or they look good. And I'm a little leery of some of those folks. But everybody you mentioned is data driven.
Prof. Noakes is captain of the ship. I think we all owe a
Yes,
debt of gratitude to his courage. So I think put him,
exactly right.
he's not seeing patients anymore. But as far as
And this is you've got this here, and
yeah, I've got it sitting right over here. My here we go.
yeah, exactly. So, and I mean, this is something that is such a good.
This is Prof, right? We have a textbook now.
Exactly, and it's a starter kit. I mean, it's the first version, and it's going to grow and grow and grow.
We both had a part in that textbook, which was a privilege just to be part of that textbook. So
absolutely,
so many people in that. There's so many people, but yeah, like you say, the ones actually doing the science or doing the clinical work, who aren't just out there making a name for themselves in the space. So there's
right. As a family doctor, you see mental health disease, organic and non-organic mental health disease. You see patients with cancer. You see patients perhaps with epilepsy. To what extent, as a practitioner in the space, and I call you told us at the beginning what you were, but I'm going to change your name. I've changed my own name. I think of ourselves as metabolic health specialists because that's what we do. But when you're looking at those other endpoint diseases, cancer, mental health disorders, and there's enough data and evidence that's coming out from these learned people, Seafried, you mentioned Eads and Chris Palmer. Are you at a comfortable level now where you are able to give people guidance or perhaps even treat people with those disorders using a ketogenic approach?
Yeah, I mean, I gave that talk in Boca this year on PTSD, because there's absolutely no downside to it. So things travel together. So many folks with whatever mental health disorder it is also have metabolic syndrome, considering probably 60% of our adult population has metabolic syndrome, and probably 20% have a diagnosed mental health illness. So that Venn diagram is crossing pretty tight. So when you have a treatment, you can suggest to someone that has absolutely no downside to it, right? There's no downside if you have metabolic syndrome and epilepsy and bipolar and post-traumatic stress disorder, to eat a real food diet that is mostly animal products to create ketone bodies and help you mobilize body fat, right? Everything moves in the right direction. So and they would give a trial, right? So, how do you know it's going to help? A 1-month trial, right?
Yeah.
Let's do this for a month. Stay on your meds. Don't stop your meds. Don't stop your bipolar meds, but just see how you feel. And yeah, we've been in some discussion with our mental health team where I work now, because we are seeing such positive effects on some of these folks with nutritional change. And then they go see the mental health provider and they're doing better. But that's, again, association, causation. We don't know, but it's curious enough that maybe downstream, but it takes, like you say, this research and publications take a lot of work. You need to get some grad students in there to really design the trials, because there's so many factors in people's lives. Like, because we know most nutrition science is nonsense because they're food frequency questionnaires. These people live in the real world. Like, how do you control if you say, okay, we have a group and we're going to place them on a low carb diet, right? Like, these aren't lab experiments. So there's a lot that goes into a prospective trial versus looking at data observationally and trying to make conclusions from that. That helps us set hypotheses, observations, but to say going forward,
But
you've got
you're
to take
comfortable using this approach for a myriad of other metabolic diseases beyond diabetes and obesity.
Oh gosh, yeah, cardiovascular disease, fatty liver is probably the biggest one we see. And they don't. It's like the silent
But
scream.
you're not prescribing resmetirom, the
is that a drug for fatty liver now?
Oh, that's a new drug that's been approved by the
geez.
FDA for and it blocks the thyroid receptor. So and
give them Ozempic. Get them to stop eating, right? I'd give them a high dose of Ozempic for their fatty liver.
Yeah, I mean, that was just for fatty liver disease, because fatty liver disease is caused by fat. It's not caused by thyroid dysfunction, not
no, it's caused by fructose mostly.
Of course, we know that.
Richard Johnson. Everyone listen to Richard, right? So he has the pathway.
So last question for you. Is there any athlete at whatever level that should not be on a ketogenic type diet?
Oh gosh, I think like the Summer Olympic Games are coming up in Paris. You're doing explosive sport. You're a 1500-meter runner on the track. You're 22-year-old, massively insulin sensitive. I don't think, I mean, if you want to be, but I don't think there's a performance benefit for those events. I think those people, they're glycolytic, they're burning through carbohydrates like crazy. They're completely anaerobic in their last 100 meters of these events. So they have to train both systems, for their own health. They need to be good fat metabolizers. That's that zone 2 training. The best 800, 1500-meter runners in the world do a lot of slower training to build the mitochondria, and that's prefers fats. But on that day that you need to, light the flames, yeah. And then for
And
growth too.
I'm really talking about. I agree with you that sugar on a
Swimmers,
day for an
swimmers,
anaerobic person, yeah, it's like nitrous. But what I'm talking about more is the athlete in training. Is there any?
adapting, yeah, train
Yeah,
low, yeah. So adaptation and training to build mitochondria, but again, everyone responds different. So I don't think you can across the board say all athletes. I think everyone should probably do a trial of it and see how their body responds.
but
But
then let me
some
flip
don't.
it around. Is there a role still for being on a high carbohydrate diet as an athlete of any kind, power lifter or sprinter or distance athlete? Is there any value still to the notion that we have to eat carbohydrates and that a high carbohydrate diet, high frequent carbohydrate diet is beneficial?
Yeah, I mean, I think everyone's an N of one. I think someone who's absolutely metabolically well, eating not junk food carbohydrates, eating fruits, eating some grains, and eating some starchy veg and training. There's some athletes training 8 to 10 hours a day, modern pentathletes. And those folks are going to be emptying the tank like every couple hours. And then, like, how do they feel, right? How do they sleep? How's their energy? Because they need to maintain muscle mass, right? So we don't want any of these folks who are training that intensely, especially during growth, if they're, 16 to 20 years old, but I think like training, right, is if it gives you a good response, good. If whatever you're doing isn't giving you a good response, don't
But you
keep
see,
doing
the
that. So
challenge is you don't know whether you can get a better response by doing something
yeah,
differently. So
do it in
often
the off
you're locked
season.
in
Absolutely.
and afraid to change because anytime you change, you're going to get worse before you get better.
Yeah. And the hard thing is, like, say you're a Tour de France rider and you're a domestique, right? You're like that journey, and you have racing season is all 12 months and it's your paycheck. You honestly probably can't. Well, let me take 2 years to fat adapt and
Right.
it's your paycheck. Because no kidding, I fat adapted and it took about 4 years. I was getting repetitive VO2 max testing. And after about 4 years, I could run at 90% of my VO2 max burning fat, but that took, time to do that, and that was with a
And
VO2
I
max
love
like
the fact that you
55.
say that. So it's not, I did this for 3 weeks and I was fat
Well,
adapted.
that was like 4 years
Right.
because I was getting
That is
tested
so
every year. And then all of a sudden it was like, shit, like I could burn 2 grams per minute,
Mhm.
almost all out. And the people had never seen that at the lab that I did. It was down at National Defense University. They're like, we had never seen this before. What, and they were like exercise science guys. And then I told them about how I eat. And they're like, oh, that kind of makes sense. I had them read,
But it took you a few years to get to that point.
yeah, because I think I was pretty ill, because I was diabetic, right? So I think before I actually got really well and thrived on low carb, right? Not just, okay, I'm getting out of diabetes now. I mean, like literally thriving on it, I think took, and I was, in mid 40s at the time, right? So almost 50 years old. So it took a
Yeah.
little bit of time. I was probably
And
pretty
that is
broken.
such an important concept because I hear I hear people
Yeah,
so
3 weeks, Louise Burke studies. What a joke, right?
yeah.
It takes Tour de France rider who's relying on their paycheck, probably can't afford to do. But Chris Froome, right? He fat adapted, won 4 Tour de France's, right? But
Right.
he's the lead guy. He's yellow jersey guy, so he doesn't need to race all year. They're
Yeah,
just going to
and
stay
no,
fit.
and unless they get an injury and they use that rehab to fat adapt, but that's true with so many athletes. They're afraid to let go because their paycheck depends. And what if they're wrong? Then they lose a season. How many
Then
seasons do
they're
they
out.
have? You know.
Yeah,
So
broken.
Do you ever pig out or eat carbohydrates or carb load?
Oh, me, no. I mean, for the last 12 years, I'm 90%. I mean, I got a monitor. I'm 90% meat, right? And eggs and fish and some non-starchy veg, and I love it. I mean, I have local farmers here. I live in West Virginia. I buy meat, get eggs from my neighbors, and it's good living.
And I think, that is such an important sentiment as well, because most people, when you first introduce this, they think of all the negatives, and it's with trepidation and boredom and, oh, this is a bland diet. You spoke of what you eat in such an exciting way. You love it. And I think that is the difference between
Oh,
sustainability
yeah.
and recidivism is you love what you do, you're empowered by what you're eating. So many people feel deprived of what they're not eating that they struggle to sustain this as a way of life. And you show how you can glow and do
Tonight
amazing.
it's going to be carnitas, eggs, sour cream, guacamole. Last night I had a pork shoulder, in a crock pot that just melted right after 8 hours. Yeah, no, you're like excited about that. And I had some organic kale massaged with olive oil. Didn't take long to prep, but it was good.
Yeah.
So
Do you
look
ever do you
forward to
ever
it.
do prolonged fasting or extended fasting?
I don't because I'm lean, right? So the last thing I want to do is compromise my muscle mass because I'm
Oh,
lean.
the reason I asked that, because obviously you are, but I referred to Ian Lake.
Yeah, yeah. So he was doing that as more of an experiment as a
Right.
type one. But for me, I eat protein. I listen to Don Layman. Like I want to maintain every ounce of muscle mass I got. So
Right.
I'm 30 to 40 grams of protein for breakfast.
But you
And
do
I
that.
don't snack
What
into the
percent?
night.
What?
Like,
How much fat do you eat? What's your fat? What is your fat to protein ratio?
yeah, it's probably. I mean, I eat real food. I eat full eggs. I eat fatty cuts. So it's probably 10% carbs, vegetables. 30% protein, and the 60% fat, or maybe if it's, but I just eat cuts as they are. I have
Yeah.
skin on the chicken. So I don't pay attention to what the macros are. I just, someday it might be a leaner meat. The next day is a more fatty cut, but it all works out in the end. It's all real food. And I think that's the human diet, right? Like I'm not
Right.
worried. I'm not adding egg white and throwing the yolks away or taking the skin off my chicken breasts. I just eat things,
Yeah,
but
it's
again,
whole
I'm not
food.
trying to lose weight. I'm trying to maintain homeostasis. And maybe that'll be our parting word is what we're all trying to do here is create homeostasis in the human again. Right. So we have this med to block this med to enhance this is going to block this side effect. Now we got to, it's like we're just whack-a-mole. And it's so everyone is out of homeostasis, and we're trying to get people back into homeostasis. And if we can help them pharmacologically to work them that way, then that's a net win. But like you're doing, Rob, the goal of pharmacotherapy is to work to get them back to somewhat homeostasis.
Correct. To restore. So I like that. I like homeostasis just means cycling. Everything in the human body is based on a feedback. There's an action and
I
equal
eat when I'm hungry. I stop when I'm
reactions.
not. I
Exactly.
wake up and I want to move. I don't have to force anything. You're like, look at the Amish farmers. Live near me, right? They end up weighing the same when they pass as when they were 20, right? They never counted a macro their whole damn life. Right? Somehow magically they're in
But they eat
homeostasis.
food. There's not a
They
lot
eat
of
food.
wrappers of stuff blowing around Amish country.
Yeah. I'm sorry, I missed that.
But there's not a lot of wrappers of
No, no, absolutely
blowing around
none.
Amish
No,
country. So
no.
no, I love this, Mark. This has been very illuminating. And
Yeah, we covered a lot of
the
ground.
nice thing, Adele Height said this. She said, look, when she created SMHP, she said, look, we're not going to find consensus, but we all overlap so extensively in terms of what we're in agreement of that let's come to an agreement about what we agree on. And the ancillary stuff is that's your personality, that's who you are. But that's what this discussion has been. There's plenty of places where you and I have a slightly different approach. But the one thing that this entire narrative discussed, even though we started with the kind of the GLP back and forth, there's so much consensus for us in terms of what we have in common. And the foundation really is very simply eat real food.
Yeah, amen. No, and help people. N of one. Everyone in front of you needs help, right? So
Yeah,
get down in the trenches with people, right? That I think without that, right? Like show people you care. It's compassion. If they know you care about them, you can help them because they trust you. And
absolutely. And I
I think
think
we're
there are good people to ask for guidance. There are good people to come and see for advice, and you're one of those. So I really, really appreciate you doing this, Mark. Thank you
Thank
so
you for the
much.
privilege of being able to share, Robert, and we'll chat soon.
We will. Take care.
Okay, bye bye.
Bye.